Welcome to another episode of the Everyday Expertise Podcast. I'm your host, Alyssa Martin, and I hope that today's conversation will expand your knowledge. Today I welcome Alyssa Martin to the show. Alyssa has spent the last few years working as a registered nurse in the emergency department of a local hospital. As with any of these conversations that I have with someone from the medical profession, I realize how much I have to learn about the work that they do, and just how unaware I am of the different procedures that they do, and some of the things that a medical profession will see. And this conversation with Alyssa is no different. As you might expect, as stories coming from an emergency department, there are some fairly dramatic stories of trauma and some of the things that she's seen. And as any story that's about trauma, there are the regular details that go along with that. So if you're someone that's affected by stories of trauma or details like this, I just wanted you to be aware of that before you start the episode. One other thing is that early on in the episode, Alyssa says that she spent 2.5 years in Haiti when it was actually just 2 years that she lived there. So she wanted me to correct that before we start the episode. I hope that you will enjoy it and learn from her expertise. Welcome, Alyssa, to the Everyday Expertise Podcast. It's really good to have you here.
It's good to be here. I'm honored.
Excellent. So tell me, what keeps you busy currently?
So currently I am a full-time student and working part-time.
All right. So if you're a full-time student working part-time, does that mean that you're 1.5 people, or how does that work?
Well, it definitely, it's a busy life. I'll say that.
Well, I'm glad you still have time to do this podcast with me here today. So, but yeah, it does sound like it would keep you busy. I know with being a full-time student, that keeps me pretty much fully busy. So I can't imagine working a job yet on the side. What is the job that you're doing? Are you still doing nursing or?
Yeah, so I'm still currently working in the emergency department, about 2 shifts a week. So.
Okay, excellent. And yeah, that's what we're going to talk about. So I'm excited to hear a little bit about what your emergency room nursing career has been like and the things that you've learned from that. So you are a nurse. So what is it that you're in school for, or what took you back to school?
So I am currently a registered nurse with a specialty in emergency nursing.
Okay.
So I actually do hold a certification in emergency nursing as well. And am back in school doing my nurse practitioner in primary health care with a specialty in global health. Okay. So my goal is to be able to take healthcare to people that have minimal access to healthcare or no access to healthcare. Okay. And I foresee myself being able to do that with the nurse practitioner program, as you can work independently and you're not actually having to work under a physician like you do as a registered nurse. Okay. So there's a little more autonomy with being a nurse practitioner? Yeah. Okay. Is that a globally recognized term, or is that a Canadian thing, or? Nurse practitioner? Yeah. So it is globally. Okay. I would say within the last 5 to 10 years, it's become a lot more popular, and there's a lot more jobs opening up in that area. Okay. Yep. Yeah. So is it something that you have to be a registered nurse before you can get into the schooling for being a nurse practitioner? Okay, so it kind of follows on that. Yeah. Yep. So you need to have a 4-year bachelor degree, and then this is a master's degree. Okay. So 2 more years. Very good. Yeah. And it might come up a little bit, and what's some of the things that have led you into that. But thanks for clarifying. Just before we hear a little bit more about your story, what got you into nursing, what got you into the medical field, are there any other hobbies or interests that you'd like to share besides your work and schooling at this point? Yeah, so I'm a fairly diverse person, which reflects in my work I do. I love anything outdoors, camping, hiking, boating, anything adventurous like that. And then just traveling, experiencing different cultures, trying different food. But then I also enjoy just like reading, refurnishing furniture, and kind of recently I've just got into growing plants. So I've been trying some new plants in my house and see how they...
So house plants.
Yep.
Very
and
good.
Vegetables and different things I've been trying in my windowsills.
Oh, okay.
Yeah.
Nice. You can grow vegetables
like just take little green onions that you buy in the store and chop the bottoms off, and they'll like sprout within about 2 to 3 weeks. You can have fresh onions.
Really? You can get them that fast? Okay. Wow. I have to try that. That's great. Have you done any medical work or nursing outside of Canada, or not at this point?
Yeah, so I actually, in my 4th year of my bachelor's degree, I did a 4-month internship in Zambia, Africa.
Oh, okay.
So I was working at a mission hospital there in a pediatric unit. And then I have spent 2.5 years in Haiti in a clinic there as well. So
very good. Was that after you were a nurse or before that?
That was after I was a nurse.
Yeah. Do you find that the way that the medical field or medical profession is approached changes depending on where in the world you go, or is it similar as far as the things you do and how you approach situations?
So I would say like overall nursing is like universal and medical healthcare. I think one of the limiting factors in a lot of those places is the resources available. Yeah. So that is partially like why I'm back in school, I guess, to be able to make some of those resources available to people. Yeah,
well, that's fantastic. So you've already said that you've had a diverse number of experiences, even within the medical profession, and with that. So what's kind of your story and how you got into the medical field, or what led you to choose nursing as a career?
So as I was thinking about this question, there's like various factors that have influenced my journey for sure. As long as I can remember, I've been attracted to injuries, caring for people. Growing up on a farm, I was my dad's right-hand helper. So I was there to help vaccinate the, pigs.
Okay.
When we had sheep, I would be the one that was like making sure that the little lambs that weren't surviving so well were taken care of, and all of that. And then kind of like another event that I can particularly remember that impacted would have been the summer when I was 12 years old. So I was helping my grandparents for a couple weeks that summer, as my great grandma lived there, which actually would be your great grandma as well.
Oh, okay, yeah.
And so I was there hired to just help with like lawn and other chores around the house.
Were you living there, or just would go there every day?
I was living there for a couple weeks.
For a couple weeks,
Yeah. Anyway, so great grandma was staying there as well, and she had 2 kind of emergency mishaps that happened while I was there. So the first one, she fell in the bathroom and gashed her head open on a bathtub, and she had like this huge laceration.
Wow.
Blood all over the floor. And I was there, 12 years old, helping clean it up, and we called the paramedics and stuff.
Okay.
And then a couple weeks later, she had a upper GI bleed, which would be like when your esophagus would start bleeding. So she's there just like vomiting blood.
Wow.
And
like you were witnessing this? Or?
Yeah, I was there holding the bucket while she's like doing this. Anyway, I can still honestly see the paramedics' face when they walked in and see this 12-year-old holding the bucket of this 90-year-old great grandma.
Like they were concerned, or what was the look?
Well, they were just like shocked. Like what 12-year-old is going to stand in the room, like, because my grandma kept saying, "You can leave, like it's fine." And I'd be like, "No, like
you want to be there." Yeah.
So that was like definitely something that started making me think a lot more medical. Yeah. I didn't really know what at that point where I wanted to go. And then when I was 18 years old, I had an incident that probably really impacted my choice to be a nurse.
Okay.
I was involved in a car accident and ended up in the emergency department. I was like strapped to a board, collared with like head taped to the bed because they were suspecting neck injuries.
Okay. Wow.
And I guess that experience kind of just left me like with a huge appreciation for the emergency staff. Wow. I can still remember just like lying there feeling like helpless. I could absolutely do nothing. And yet the care and compassion that I really felt from them. So that kind of obviously, by that point I was 18. I'd already been through high school. In high school I had like no idea what I wanted to do for career. My guidance counselors were kind of guided me towards that direction, as they were like, they saw my grades and were like, you could do this and this and this. And so I did do like a biology, chemistry, math.
This was towards the medical direction, or what did in high school? Yeah, okay.
Yeah, so in high school, like they would have like put me kind of on that path,
saying do the things that would allow you to pursue like, that if you decide to.
You're capable of doing it. Yeah, do it.
That's great.
So that's kind of what I did. And then during high school, I started working at a nursing home.
Oh, okay.
And I would like go there after school for a couple hours every day. Go there on the weekends. And then when I graduated high school, I enjoyed it enough that I asked them if I could get a full-time job. And they were like, no, you need to have a PSW, or like personal support worker.
Some kind of training. Yeah.
Yeah. Which at that point was actually brand new, because I used to just grandfather students into that position.
You'd learn on the job.
Could just, go with it. Anyway, so that kind of took me back to school. The year after I finished high school, I did the PSW program, which was like a 6-month program full time. Finished that, and it was kind of through that 6 months that I knew that I wanted to go back to school for nursing.
Further than the PSW,
but decided that I would like work like a year or two full time before I pursued further education. So that's what I did. I worked for 2 years, and then I went back to do my bachelor's in nursing, and that's where I am today. Okay,
very good. Were you working at the nursing home for those 2 years?
Yeah, I worked
in a long-term care, or
in a long-term care home.
Very good. Yeah. So was you said that at 18 you had that experience. Is that how old you were when you had that experience where you were in the emergency room as a patient? Was that something then that was kind of in the back of your mind as you prepared to go through the nursing program, or when did you realize that was something you'd like to try?
So I think all the way through the program, I was always interested in critical care.
Okay.
So either ICU or emergency. I didn't clearly know exactly where I wanted to end up until I ended up there. But it was definitely always in the back of my mind. I knew something critical care compared to like home care or something like that.
Right,
at that point.
Is there something that appealed to you about it?
Well, probably like I've already alluded to, I like adventure, and the adrenaline rush was probably kind of attractive. Yep. I think one thing that did allude to it too, because before I ever applied to the nursing program, I was very interested in like first responder, like paramedic, that type of stuff. So the pre-hospital was always something that was in the back of my mind. And the emergency department was the closest to that.
As far as a nurse gets into that. Yeah. Very good. So did you go right into working in an emergency room when you graduated then, or have you done other things as well?
So I did. I actually had done my final 4 months of consolidation in the emergency department. Yeah. So I wasn't planning to go straight into emergency nursing, but got hired on as staff like during my final 4 months there. But it kind of ended up being a bit of a longer journey to the emergency department than I was planning. So just backtracking a bit, when I finished school, I got hired on as a student and got a temporary license. So I started working, getting trained and everything. But then when I went to write my national exam, I actually failed.
Oh, okay.
And that was like a huge shock to my little world.
Yeah.
Everything I had kind of been like dreaming for fell apart, and I didn't really know what else I was gonna do. But it was kind of through that time then that the doors opened for me to go to Haiti. So
okay.
I actually went to Haiti straight from school. Pretty much.
So did that mean that you couldn't get that job as a that you were planning to do right out of school? Is that because you failed the test?
So yeah. So like as soon as I failed, I like lost my job. Right. I lost everything about it.
Could you not try it again? The test again?
I could, yeah, which I did.
Yeah.
And backtracking a little bit, like obviously I was very shaken by this because school was never really an issue for me. Mm-hmm. But it turned out that I was actually one of the so I've been put into fast track programs. So I actually completed my bachelor's in 3.5 years. Okay. And the Canadian Nurses Association had implemented a new international exam. Okay. So they took the American national exam and brought it to Canada, but had not actually, my set of students were going through to write the Canadian national exam. Like
you were studying, preparing for the old
CNER, one. And then they brought the NCLEX in. Mm-hmm. And so what actually happened was there was like, I don't want to say, I think it was something like 80% of the students that wrote that first write failed. But obviously, none of us knew that initially. And we were all just like, because it was like, technically they're elite students writing this first national exam, and 80% failed. Did you
have a bad feeling as you were doing this, like doing it, or did you feel okay about it?
I didn't feel great, because the thing was that the medication dosages on it were like all in American.
Okay. Did you know that was going to be the case, or did it totally surprise you? Okay.
Yeah, I had no idea.
Why did they didn't tell you at all?
Well, it was
that's amazing.
Typos and stuff. But anyway, so I did restudy to rewrite, which by that time they had already revamped the exam to Canadian. Okay. Because they had never changed. They didn't change like the medication names, weights, so like all that type of stuff that would all be in American.
There's different language names for things.
Oh, absolutely.
Yeah. Okay.
Yeah. Wow. So you're writing along and you're like, I have no idea what this is, but.
Wow.
So yeah. So anyway, and then I went to Haiti for 2.5 years, and actually, when I came back, I contacted my manager again, who had initially hired me. Okay. And they called me back in for an interview, and I got hired on into the same department where I had left initially.
Okay, I see. Yeah. So did you do your test before you went to Haiti? Okay, so you did.
Yeah, I rewrote within like a month. I see. Okay. Something like that.
By that time, you'd kind of changed your plans because of this situation and went there. Okay, very good. Yeah. Anything else that you wanted to say on that up to this point?
No, I don't think so.
Okay, so anything significant then from starting your job in the emergency department until now? Anything that's kind of changed or significant parts of your story since then?
I can't really say that there's been a lot. I feel like when I came back and just went to the emergency department, I knew it was something I enjoyed. Mm-hmm. But just starting back in, I really realized how much I wanted to learn and enjoyed it so much that's what actually made me go back to get my graduate certificate in emergency nursing. Okay. So that I could like just learn more and be the best I could be in that area.
What did that involve? Like.
So it's like a 3 to 5 year program part-time.
Oh, okay.
With like, I think there's like 15 to 16 courses that you can do out of it. And then it prepares you to write the Canadian Emergency Nursing like national exam. So like there's a national certification for.
Okay. So you don't need that to work in an emergency department?
They recommend it, but a lot of people don't have it.
Okay. Yeah.
Yeah.
But did you find that it prepared you for a lot of situations that you see regularly, or?
Absolutely.
Okay.
Nice. It went over a lot of situations that you see every day, and like assessment skills, and just being able to, when you saw a case come in, I feel like I can look at something and I pretty much predict what the physician's going to order and what our next steps are going to be to get the patient through the department.
Yeah, very good.
Yeah.
Was doing your signing up for your nurse practitioner schooling that you're doing now, was that something that you always were thinking about doing too, or is that something that kind of developed as you were working as a nurse?
So I honestly, when I graduate, never figured I'd go back.
Okay.
Working in Haiti though, I think is kind of where it started, like developing that I was like, oh, I could actually do this, because I was working largely in the role of a nurse practitioner, physician, whatever, but I was a registered nurse.
Does that mean there often wasn't a physician that you were working with? Or?
So physicians were all satellite, except one would come like maybe every Friday.
Oh, okay, yeah.
If that, but they weren't necessarily there when you needed them the most.
Right. So does that mean you'd try to do as much as you can without involving the physician, or like does that mean you would do things that you wouldn't have necessarily done if the physician would have been there? Like did it?
Absolutely.
Yeah.
So I definitely had a way broader scope of practice.
Yeah, very good. Yeah. Anything else that you were planning to share from your story before we talk about some of the things that you've that you do as part of being an emergency room nurse?
I think just one more thing I kind of want to point out is just recognition to my parents. So I feel like they have been a huge support in where I am today.
Okay.
They have given me the ability to dream big and allowed me to dream big and just pursue what I feel like God's calling me to. And even though I think sometimes they have to kind of question all my big dreams and ideas, but
that's not necessarily bad.
With it.
That's not necessarily bad either, though. No. To get you to think about, okay, is this realistic? What you're planning? So
I think I just want to give them recognition, as they are definitely a huge part of my story.
Yeah, well, that's fantastic, and I've had that experience too of very supportive parents in what I'm doing, and I think about being a parent now too, how valuable that is to have a parent support, and thanks for sharing that. So talking about now your experience in working in an emergency room. Do you call it emergency room or an emergency department? I guess ER, is that often what it's referred to, or?
You can call it anything. I find in Ontario here especially, they'll often talk about emerge nurses versus if you talk to like some of my friends in the US, it's always the ER. So we kind of use it interchangeably. Okay. ER, ED, emergency department, whatever.
Yeah. So what would you say are some of the skills that are necessary for an emergency room nurse?
So some of the ones I can think of initially are definitely like flexibility. You need to be very adaptable, so because things are constantly changing within your department. And then just being able to remain calm in the midst of chaos. Think on your feet. Have critical thinking and critical assessment skills. So when you see a patient walk through that door, immediately knowing if they need immediate help or if they'll be okay to wait for a couple hours.
And is that because if you're like busy, then you have to decide who you need to take care of first, or why are you making those decisions?
So definitely it would be partially that. And part of it is just, as an emergency nurse, which we'll probably get into a bit later, is every single patient that comes to that door gets assigned what we call triage level. Okay. So, looking at them and being like, that patient needs immediate attention, or they could die within the next 5 minutes. Right. Okay. Or that their patients, they're pretty sick, but they have a couple hours or a couple days, right? Like you have time to do your investigations. And a lot of it, I think, is to know how to allot your resources. So if I take patient who could wait a couple days per se and send them right to an x-ray, but meanwhile I have someone come in who could die within the next 5 minutes. I need those resources. So you're kind of thinking about that all the time.
Okay. So even if it is like, I don't know, if you ever get slow days or nights, are you trying to think about that? Like trying to think about the fact that at any time, an emergency, like a very serious emergency could be coming through the doors?
Absolutely.
Okay. So that's always in the back
of your mind all the time.
Yep.
Yeah.
That's I hadn't thought about that part of it, that you always have to be prepared for what could be happening. Do you have a heads up, like if there's an ambulance en route or anything like that, or do they come in and that's the first you know about a situation?
So so EMS or ambulance, we always call them EMS, Emergency Medical Service. Mm-hmm. They will they'll call patch in. So they will call into us, like dispatch into us, and be like, we're 5 minutes out. And they'll tell us a story, give us their assessment, and then that helps us to be able to prepare.
Okay.
Sometimes in like situations where there'll be multiple casualties coming in, say like a huge motor vehicle accident with multiple people, we might actually get a call from dispatch before the ambulances leave the scene.
Oh, okay.
To be like, you have like, this amount of casualties coming in, just so that we can get our whole department prepared for that. Okay. And then you'll have a little bit more of a warning before they're on their way. Yeah. So, anything else that you wanted to say about the skills before we talk about some of the procedures and things that happen to within the emergency department? So I think another thing is that and this is kind of like the education side of it. There's a lot of continuing education that is required. So the emergency certification that I have is not necessarily required, but there's a lot of courses that are required. So if you're thinking about being an emergency nurse, on top of your nursing, you need to have like training in trauma, pediatric trauma, all your life-saving courses, and how to read like ECGs, so like the changes on the cardiac monitors. So all those type of things are very pertinent. And is that like, can you get that as you're on the job, or is that all things you need to even be considered to be hired in a position? So some it depends. It's very hospital specific. Some of the hospitals would provide you the courses once you get hired and say you need to have them within like 6 months. Is often the time frame. Some of them would want you to have that training before. Yeah, I was kind of, as I was thinking about talking to you, I was wondering if you found that more of your skills come from the experience of being in situations that you learn from versus the training that you get in preparation for situations. So if you look back now on the skills that you've gained from both schooling and experience, what would you say has been more significant with the skills that you have now in preparing you for situations you're in? So I think obviously on the job is probably how you learn the best. And I think it's very important for people to have the background. It's kind of a base to put things on or to grow on. So you can go through these courses and like at least you have your assessment algorithms and different things like that they distill in your brain. And then when you're on the job, like I'll take for instance, so our trauma course, you have an algorithm. It's A, B, C, D, E, F, like all of those stand for a letter. And a patient comes in and right away, I think A, airway. Is there airway patent? Do I need to intubate right away? Do I need to start bagging? Okay, that's good. I'll move to B. B, are they like breathing on their own? Is their breathing labored? Is it like, seesawed? And then I move to C and I'm just like, that circulation. So do they have a good blood pressure? What color is their skin? And you just like, you move through that algorithm and that's what like leads your assessments. Can you keep going? Like how far does it go? So it goes to F. So then you have D is like disability. So how alert are they? Are they talking to you? Are they confused? And then E would be environment or exposure. So environment is thinking about what was around them at the scene of like say an accident or anything like that. And exposure, you then would undress them and look for any injuries.
Okay.
From like head to toe.
Okay.
And then F is like doing your full set of vitals and any additional like tests that you might want to do. So like ECGs, X-rays, labs, catheter, anything like that.
Okay. And this is a list that you go through for anyone that comes in, or is it just for trauma situations?
Mostly for traumas. Okay. But yeah, you would have like for every situation, you have your different like algorithms that you run through. Yeah. And they're not posted anywhere in the department. It's things you've learned, right?
Okay.
And, yeah. But you'd only learn that through education.
Yeah. That's neat. That is that actually the order you follow, like through the alphabet like that?
Yeah.
In that thing? Well,
and it's funny. You will have a whole trauma team. So say you have let's take for instance, you have someone come in with in a motor vehicle accident, and paramedics bring them in. You'll have your physician there. You'll have a couple nurses, and the paramedics will like be going through their story as they're doing that. But while they're telling the story, you're gonna see like the physician and a couple nurses just like walking through. Like the physician will be like, airways patent, breathing. What's his blood pressure, and you just walk through that whole scenario, and that's. The whole team knows what's happening, right?
Okay, yeah.
And then they get to like, say they get to blood pressure and they're like, no, he's like hypotensive. It's like 60 over 40. He's like, we need to give fluids. We need to give blood. We need, and you'll act on it when you get to something that's abnormal, right? So.
Oh yeah, no, that's interesting. Very good. So you told me that you'd kind of like to take us through the process of what it's like within the department. If someone comes in, what are kind of the process or what you go through. This probably be a good time to talk about some of the tasks and things that you as an emergency nurse do. So what are take us through that procedure, that process.
Yeah, so I think that's one thing that with an emergency nurse, you have a very diverse role that you play. So you can play different roles on different days per se. So I'm going to take, for instance, like one day you might be charge nurse.
Okay.
Now that varies. Like if you work in a small facility, you might be put into the charge nurse role a lot quicker than you would be in a larger facility with 20 some nurses.
Okay.
That would be like a designated role. And so when you're charge nurse, that means that you are allotting all the beds. So whenever EMS patches in, tells me what the situation is, and I'm just like, this patient's going to need to be a resuscitation. Let's put them in like trauma 1. Maybe they'll patch in and I'm like, you know what, that patient doesn't really need an acute bed.
Okay.
They just might need some x-rays or some fluids, so I'm just going to put them into room, I have room 1 open, let's put them there.
Okay. So
you're constantly when you're charge nurse, you're constantly prioritizing everything that's happening in the department, making sure people are in certain roles. If you have a, recess coming in, you're making sure you have the staff all there that you need at that time. Making sure x-rays called, labs called, additional physicians, additional nurses, whatever it may be.
Okay.
So there's a lot of just leading out, and then obviously you're doing tasks too, but you're really facilitating that the department's running smoothly at that point.
Yep.
And then you have one of your next, everyone's a key player, but one of the next people then it would be your triage nurse. Okay. So when you come into the hospital, you would probably register, and then that puts you in a queue to be seen by a triage nurse.
Okay.
And so that triage nurse is going to get what your main complaint is, ask you some questions, and just kind of get a feel of the story. Okay. And through that story, that's going to make her assign you a triage level, we talked about. Yep. So say you come in, for instance, with abdominal pain, and you're having this severe abdominal pain. You're saying it's 10 out of 10. She can see you walking in the door, you're grimacing. She can tell you're in a lot of pain. Maybe you vomit in your triage room. You have a fever. You're going to get scored pretty high on something like that. Yep. If you come in with your abdominal pain and you're drinking a coffee, those are so. Yeah. But then you take the vitals, you take the patient's story, and that cues you into a triage level.
Okay.
So then what that does is we have our triage levels are like 1 to 5. So a 1 means that probably your heart stopped or you're could die.
So that's really
5
serious.
minutes. So that's like you get seen by a physician immediately.
Okay. Yep.
A CTAS 2 is less severe. So like obviously you're still really sick and you could go south very quickly. But you have some time to work with.
Okay. You're not there yet.
Exactly.
Yeah.
And then 3 is like, less than 4 and 5.
So 5 is the least critical.
5 is like often what your referrals, like someone just coming in to see a physician, or they're just wanting a prescription refilled.
Oh, yeah.
Anything like that could probably wait a couple days, or they just can't get into the clinic or something to see. So that's your triage nurse. So then she's now assigned you a queue, which now the charge nurse can see, okay, so I have a CTAS 2 out in the waiting room. That CTAS 2 needs to come into an acute bed. So that's how helps the charge nurse to decide what beds and where in the department people are going to go and how soon they should be brought in and everything like that.
So you might have been assigned a level 2 and still be in the waiting room, like waiting to get assigned to go somewhere?
Yeah,
okay.
if our beds are full.
Oh, I see. Yeah.
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 But that's the beauty of like a triage nurse. Well, really the beauty of the emergency department is we have a lot of medical directives.
Okay.
And what that is that's a lot of orders that are pre-assigned per se that nurses can implement. So the triage nurse will see someone who comes in with that abdominal pain, for instance. She can now initiate blood work for that patient, probably not x-rays, a urine sample, and have all of that stuff done before they ever are seen by a physician.
Okay, so is a nurse not normally able to order those things? Is that the difference in the emergency department?
Yeah.
Okay.
So that's one thing, like in an emergency department, where you have a lot more autonomy in those areas.
Yeah.
Being able to order that, IV fluids, different medications.
Okay.
Yeah.
Yeah, very good.
So then you're waiting in the emergency, or then you're waiting in the waiting room. And then in the department, you're going to have multiple nurses as well with different roles. So you're going to have your trauma nurse. And that is the person who's going to be leading any trauma that comes in. So when, say, that MVC that comes in, you're going to have one nurse that is there, calling lab, assigning everyone their roles. So you do medications, you take the cardiac monitor, you do the IV. So really the one that's leading that trauma.
Okay.
And making everything run smoothly.
Sorry, were you referring to a specific type of thing there? What did you say, MVC, or did I?
Oh, motor vehicle accident.
Oh, got you. Yep.
Yeah,
yep.
MVC. That's our acronym.
Got you. Yep.
Yeah, you can clarify anything that I. So that's your trauma nurse, and then you have, then you kind of have your other areas. So you have your acute area for like your obviously quite acute patients, your chest pains that will need to be put on cardiac monitors, anyone who's seizing, patients who might have like really low blood pressure, anything like that need really close observation will be put into the acute area.
Okay.
And that area needs higher trained emerge nurses. So you'd need, like, people need to have like all their courses plus to be able to work in some of these areas. And then you would have your what we call kind of just like intermediate areas. So people that aren't quite as sick, like maybe your elderly patients that aren't coping well at home, probably just need admission. Your mental health. So that's a huge thing in the emergency department as well.
Yeah.
And then you would just have our last area is like your ambulatory care. So you come in with a laceration to your finger. You obviously need to see a physician, but you can walk and talk and sit in a chair to wait to see them. So you don't need a bed.
Okay.
So those are kind of like the different areas in the department. And then as a patient, you would be brought in from the waiting room and assessed by a nurse. So a triage nurse has done the initial assessment.
Okay.
And then you are assigned to a bed, and another nurse will bring you in and do what we call a secondary assessment.
Okay.
So this is a much more in-depth, like, listening to your chest, examining your injuries. And then from there, she'll decide if maybe you need some IV fluids,
Mm-hmm.
get that going. You need something for pain, she'll give you something for pain.
Okay.
Whatever she can prescribe without a physician.
Mm-hmm.
Get you sent for x-rays if you need them. And just trying to get as much as you can before the physician comes to see them.
Okay. Yeah.
Just to speed things up.
Okay. Yeah. So are these like things that you would do a bunch of these different things that you've been talking about, or do you specifically take one of these roles every time that you're working? Or would you get moved around within the different things you've been talking about?
So you would initially probably you'd be designated a role in the morning. So when you get to work, you would look at your assignment and see where you are that day.
Okay, but you'll do any of these things?
So I roll through them all. Yeah. I go through them all.
Okay. Yeah. Had you covered what you were going to talk about there, or?
Yeah. I don't think there's anything else to add.
Very good. So those were all nurses that you were nursing roles that you were talking about there, which makes sense that you would do any of them. So what are some of the other staff or people that are on the emergency department team? Because it's not just nurses, right?
No. So the emergency department is made up of a lot of people, which is really multiple disciplinary is what we would call it.
Okay.
Mm-hmm. Obviously physicians. Mm-hmm. We'd have nurse practitioners.
Okay.
Some hospitals will have respiratory therapists, which I believe you had one talk a couple weeks ago. Some don't.
Okay.
So in the hospitals that do any airway stuff, the RTs would take care of.
Right.
In the hospitals that don't, that's the nurses. So I would do a lot of airway management as well. And then we have social workers. Okay. So use them a lot. Pharmacists are there. They will often come and help in your recess or code situations when you're pulling and mixing a lot of meds. They'll actually often come and help mix our medications for us, which is really nice. Crisis workers. So those are the people that work with our mental health. So you have someone come in who needs just to talk with someone. Either we have crisis in-house or remotely. It really depends, again, where you're working. Yeah. Security. Mm-hmm. So they're another huge part of our team, and we use them a lot. Then just your clerical staff, CCAC, CCAC would provide resources for the home care. Oh, yeah. So they make all the referrals and get that stuff set up. Mm-hmm. Our lab techs, x-ray, CT, ultrasounds, and then other specialists and stuff that would be called for different situations. Okay. And so it seems like a lot, are these all ones that work right in the emergency department, or just ones that or some of them ones that you would kind of coordinate with depending on a situation? So all the ones I mentioned would work right in the department. Obviously CT and ultrasound and x-ray are right off, but would be there all the time. Okay. Right? So you're working with a lot of people every day. Yeah. Well, so are these, would some of these depend on the size of the hospital and what resources they would offer, or would any hospital have all of these different options and workers? So it would really depend on the size of your hospital. So in your little rural hospitals, you would not probably see nurse practitioners very rarely, just because the volume's not as high. Respiratory therapists aren't there. Crisis workers will probably be remote, and security will probably not be available. But the rest would all be within house. Yeah. Yeah. Well, very good. Anything else that you wanted to say about kind of some of the general workings of an emergency department? Another thing I thought I should mention as well is, so those are the people within the department, but then there's a lot of people we work with that aren't per se right in our department, but we work with a lot. Okay. So our paramedics, we work with them a lot. They're bringing us patients. We do transfers with them. So it's another role as an emergency nurse. You actually go out with your acute patients to transfer them to, different hospitals. Oh, you'll ride along. Yeah. Okay. Yeah. Especially with your critical acute patients. Flight paramedics. So we fly a lot of people out by helicopter. Okay. So you work very closely with them. The police, we would have very frequently, they bring a lot of people to us and just call them for various situations. And then, child and family services, poison control, and I'm sure there's lots of others, but those are kind of a few that we would work with. pretty much on a daily basis.
Okay. Yeah. Well, what would you say is the most enjoyable part of your job?
So I think probably one of the things I love the most is just the diversity of ages. Some departments are specifically adult and some are just children. Okay. But the departments that I work in are all like across the lifespan, so 0 to 100 plus. I like that. I like the feeling of just never knowing what's coming through the door. So you can be like, oh, it's really nice, and someone might actually just go get coffee right before they get back. The department's like chaos. Okay. It just seems to be how it happens. And another thing that I really like about my job is I feel like I get to observe miracles like every day. So the reason I say that is we see a lot of people with injuries and trauma that should never have survived. Okay, yeah. You have like a farm accident or motor vehicle accident or fall where if you hear the story and how the mechanism of injury, they really shouldn't have survived, but they might walk out with very minor injuries. Okay. So it's really like, yeah.
Yeah, that's fascinating.
Amazing.
Is there anything you don't like about it?
I can't say there's nothing I don't like. I think some of the hardest things I find with my job are, delivering bad news. So we have a lot of people that'll come in with a very vague complaint, and you do investigations, and you might have to tell them that they have, cancer, and they don't have very long to live, or you have a family who's there because their loved one didn't survive, like in a ATV accident or something that. So we have a lot of that we're dealing with. And then another thing I find kind of conflicting probably is that, you can be in a trauma or recess for like hours at a time, and you might walk out of there and the patient didn't survive, or they're hanging on by a thread, but then immediately you have to walk in to see the next patient and like be happy and pretend that nothing happened and feel like the reason they're there is just as important as what this other person was, but I don't feel like that all the time. Yeah. So that's probably one of the most conflicting things and the hardest part of my job. Yeah. Do you almost like feel calloused in a way? Like, do you almost have to do that to be able to forget about a tough situation like that? Or how do you do that? I definitely do feel like I have yet to become very calloused, or I feel calloused. I think one thing that I have found for myself is, so I might have to do that at work, but then you need to release that whatever happened sometime, right? So it might be on my way home from work, I might just start bawling or listening to music or journaling, or you need to have some way to reminisce the situation and like process it. But you need to always remember, obviously, confidentiality. So you can't be just like talking with anyone about it, but you need to find resources and people that you can like process things with. Yeah. Sure. Yeah. And like, do you find that you can't let it, you do have to kind of draw a line of how much you can let it affect you? Do you find that, or? Yeah, I do. I find that some situations might affect me more than others, and I'm not always exactly sure what impacted that. But I find that when I'm in the situation, you're there to do a job. And it is amazing how when you're so focused on, saving someone's life, that sometimes the situation itself doesn't really affect me because we're so focused on a task. Okay, yeah. It's when I like walk away or like a day or two later and I'll be just like, wow, like that's when it'll start just like really like coming back. But that's where you need to have a great team. Like, I feel like I work with amazing people, and we will sometimes a couple days there just sit down and just like talk through that situation. What went well, what didn't went well, how people are feeling. And okay, well, yeah, that's great.
And yeah, I'm sure that helps a lot to have good people to work with.
Absolutely.
Yeah. I put down the question here because I have a little bit of an idea. I mean, I think probably everyone has some experience with either someone they know well, a loved one, or themselves having been to an emergency department, visited at some point as a patient. And so I feel like I have some idea, but I probably don't know very much about what actually goes on and what the things are that you deal with. So what would you say are the most typical cases that you would see in an emergency department?
Well, so obviously, like any other thing, you have your kind of routine things that come through the door. Your, respiratory. So like it's coming into winter, we have all of our viruses and pneumonias, all your kids with fevers and earaches. We see a lot of like abdominal pains, which turn into appendicitis and gallbladder attacks. And those are very, very common things that you see come through the door many a day. Other injuries, so like ankle injuries, wrist injuries, whatever. Those are very common things that you see coming in.
Like a broken bone would always go to the ER or to the emergency department? Yeah,
absolutely. And that's appropriate because that's where... Yeah, it is painful, but we have resources to x-ray immediately.
Okay, yeah.
And most of our physicians would reset that bone and cast it, and then you'd be referred to an ortho to see a specialist. So that's not like something you would go to your family doctor about.
Okay.
But then other things that are actually quite frequent, I would say, is your complaint of chest pain. So that can turn into a heart attack, which is actually very common. We see a lot of heart attacks. Some of them are acute, and some of them are what we call non-acute.
Okay, so just define what you mean by acute or what that looks like in a heart attack.
So acute is when someone comes in, we would obviously do a ECG. Do you know what that is?
I don't know.
It's a electrical cardiogram. So you put a bunch of stickers on somebody's chest. And it takes 12 pictures of your heart.
Okay.
And takes pictures of the electrical impulses of your heart.
Okay.
And so what we do is we can look at that and see if there is, so in a, when your heart pumps, you're going to have the valves are going to open and close. And this electrical cardiogram reflects that.
Is it like a graph, or what does it look like?
It is like a graph. Yeah. So you can see the impulse of the heart open, and then it closes. And what we'll do is we'll look at that graph, and if you see any changes in it, then you know that there's something going on with the heart. So maybe, but by looking at it, if it's acute, you'll see that there's an elevation, what we call ST elevation. So there's an elevation, and what that means is that the event is currently happening. And if like that, there's a clot in the heart, and it is currently blocking, or just there blocking right now, pretty much. It's not completely blocked yet, but it's blocking, starting to block. Okay. So what that means is we have time at this moment to give you a medication that can burst that clot apart. And your heart can function, and you're not going to have complete occlusion of that vessel to the point that part of your heart muscle is going to die. And so that's our aim. So if we see someone with like an acute STEMI, what we call it, then we will initially give them medications to break up that clot and try to get them to like a cath lab, so someplace where they do heart surgery. But then the other ones you'll see are what we call non-acute. And that means that we'll look at that graft and we can see that there's changes in the repolarization of the heart. So like when the heart is relaxing, but it's not currently happening. So the changes now are what we call depression, and that means that there is a clot in the heart, in one of the coronary arteries, and a portion of the heart is not getting any oxygen.
Okay.
And depending on the severity of it, we can see that a portion of the heart's actually quite dead already, and you're probably never going to get any function again.
Okay.
So in those situations, we'll give them stuff to break up the clot. They'll probably still go to the cath lab and have like what they call an angiogram. They put like a dye through your heart just to see how bad the damage is.
Okay.
But at that point, it's very hard to reverse the damage that's already done.
Yeah.
So it's not considered like, I mean, obviously we still treat that patient, but they're not going to be rushed to the cath lab.
Because there's not as much that you can do.
Because you can't reverse the changes. Like you can if that clot's just starting to move into that vessel.
Okay. So it's not actually that they're better off if it's non-acute than acute. But it's how much you can deal with it at the moment. Is that why you use that terminology?
Yeah.
And are there still like levels of severity within those two? Like, can you have a really bad acute situation but not as bad, or?
Absolutely. So it really, and again, that electrocardiogram, you can see what areas of the heart are being affected.
Okay.
And there's different coronary arteries. Some will feed two parts of your heart, and some of them will only do one part. And we can see if it's only just a small portion affected, or if it's like half your heart affected, which is obviously not a good thing. And so but within that, as soon as you see acute, you want to treat immediately so you don't, that they can have full function of their heart again. Okay, yeah. So, yeah.
And so that it'll usually be chest pains that prompts that?
Yeah, so typically people will come in with, sudden onset of chest pain. They might feel nauseous. The pain will be radiating down their left arm most typically.
Okay.
They'll often what we call diaphoretic or really sweating. Their skin might look really pale. But really it can depend because you can then so that's a typical presentation.
Right.
But in women especially, you'll see that they don't present typically. So a lot of women will present with just having some what we call epigastric pain. So pain in your upper abdominal pain. And it'll feel just kind of like heartburn. Okay. And they'll be like, I just have this bad heartburn that I can't get rid of. And oftentimes they're having a heart attack.
Okay. I see.
So that's a very common thing and very acute thing that we deal with for sure. And then other things that we would see a lot is just heart, there's a lot of things with the heart. So we'll see people coming in very fast rhythms. Oh, okay. And then we can actually slow that rhythm down. So that can be either by giving them medications or else we'll use our defibrillator and actually shock them back into a normal rhythm.
Yeah. So that's just that the heart's beating too quickly?
Too fast. Yeah. Yep. Yeah. And then we also have your bradycardias, which your heart's then going too slow, and that's very dangerous as well. For some people can tolerate it really well. But again, we'll often do what we call pacing, and that is taking the defibrillator, having pads on your chest, and they literally just pace it. So every time that the heart beats, it gives an extra beat to get you back to your normal rhythm. Okay. Yeah. Shock them back into normal rhythm. Yeah. Yeah. And then some of your other things that we see is obviously we see a lot of trauma in where I work as well. So farm accidents, falls, motor vehicle accidents, ATV accidents, really anything like that. So which involves in a lot of head injury, multiple traumas, blunt traumas. You'll have things sticking out of people's chests. Whatever else. So.
And depending on the situation, they might have multiple.
Absolutely.
Is that what you were saying?
Yeah. So multi-trauma is what we would.
Okay. So that might be a broken bone and a cut somewhere. Yeah.
Yeah. Or they could have a head injury, and their femur bone is completely cracked open, right? So.
Do you almost have to decide what's most important to take care of first too? Is there triaging within the traumas on a patient too, or not?
So again, that's where that ABCD would come into
play.
Oh,
okay, yeah, because those are the most important things.
So airways obviously always at the top. You'd always intubate first. But then if they have a huge like laceration and they're bleeding out their leg, well, that's your circulation because now they're hemorrhaging. Those two would kind of coincide together.
Okay, yeah. Yeah. Were there other things that you were going to talk about there, or did you cover everything?
I think I'm just going to mention one more area that is the mental health.
Oh, yes, yeah.
So mental health is huge. We see a lot of like overdoses, a lot of self-harm, anxiety, depression. And yeah, like an area that I don't feel near as competent in as some others because you can't always just go in with your algorithm and fix them.
Okay, yeah.
Right? It's a lot of just like mentoring and talking to people and trying to help them find resources. So definitely a whole different area to work with.
As a nurse, are you trained to deal with a lot of those situations, or are there others that are more prepared to?
So we would get some training. We have a lot of like our crisis workers are actually nurses. Okay. But they would be trained more in mental health.
Okay. Yeah.
So we would rely on them a lot to help navigate those situations for sure. But with them especially, we would use a lot of. So there's a lot of situations where patients are a huge harm to themselves and a threat to others that we have to use like Pinells and sedation measures and stuff to retain that patient, as it were, to keep them safe. So we do a lot of training with that and work with that a lot. But yeah, definitely don't feel it's my expertise near as much.
Okay, yeah. Yeah, you talked about a number of different procedures that you do with depending on the trauma situation that comes in. Were there other things that you wanted to mention about the procedures that you regularly have to do?
So definitely IVs is like probably one of the main skills and procedures that I do regularly. And then that would include like, giving IV medications direct, which is a huge skill that emergency nurses have. Is just like to be able to give life-saving drugs via IV, like
and that just gets
a syringe and you just push it in, right?
And it gets it there really quickly. Is that the idea?
That's the idea. Yeah, within some of them can work within like a minute to 2 minutes.
Okay,
depends on what drug you're giving.
Okay. Yeah.
And then obviously so fluid resuscitation, we do a lot of that. Sometimes we do what we call pressure fluid. So we will actually put the fluids in a bag and give it under pressure to try and get it in as fast as you can. Sometimes if that's not fast enough, you actually have nurses squeezing the medication in because you want to just get that patient fluid resuscitated as quickly as you can. Or with blood, you're doing it with either or.
Sorry, Ed, what do you mean by, what did you call it, fluid?
Resuscitation. So giving them enough fluid to get their blood pressure back up to a certain level.
Okay. So is that when they're too dehydrated or not necessarily?
Could be dehydration. It could be blood loss.
Oh, okay. Yeah.
Whatever. Anything that'll normally dehydration or blood loss would be the main ones.
Yep. Yeah. Anything else there?
So other things that we would obviously do are then relate to the fluids. We do a lot of fluid warming. So when, especially in our traumas, again, you have someone come in who was in a motor vehicle accident out in the cold and they come in, they're hypothermic or too cold, right? So then we would put all of our fluids and blood through what we call a fluid warmer. And it's literally just a warmer that we can put on our pump and all the fluid goes through to body temperature.
Okay.
So that when it gets that's how we would warm our patients oftentimes in those situations.
Sorry, this is new fluids that are going in, or you're circulating fluids?
This would be the new fluids going in. Yep.
Just to
blood
have a little bit higher temperature as it's.
Yeah, just to get that body temperature back up to normal temperature.
Okay.
Yeah.
Oh, yeah, I didn't know that.
And also we would do a lot of warming with that as well. So we have these heating blankets that you can put over the patient. It's called a bear hugger, and it literally just will warm the patient, helps warm them up and stuff. Yeah. So something we do a lot. I like I talked about defibrillation. So obviously we would do that in our CPR as well. When we're trying to resuscitate someone, if you have a rhythm, you're going to shock. And so we would do a lot of defibrillation. Do you know what that is?
I think so. But go ahead and describe it just a little bit.
And well, I'm gonna also go on to the cardiac monitors, which they really coincide together as well. So obviously, any critical patient that comes in, we put on a cardiac monitor. So that pretty much is just to be able to see what their heart rate is, and it will assess their blood pressure and pulse and anything like that, just so we can see it. And then that coincides with our defibrillators. So, you have someone, you're resuscitating, and you do your pulse check. You don't have a pulse. You see on the monitor that you have a rhythm. So then you're going to shock. Okay. And resume CPR. So
what do you mean by you have a rhythm?
So sometimes you'll still have your electrical impulses. When you're doing CPR. So what you're going to see on your monitor is you're actually going to look like you have a rhythm. It'll look like you have a rhythm. It might even look like normal sinuses, which a normal person is in a normal sinus rhythm.
But you don't have a pulse.
But you don't have pulse. So then you're going to shock that to shock the heart to try and get them back into a normal rhythm to get that heart to pump.
So when you talk about a rhythm, are you talking about the body telling the heart to beat, or what is that? What is that electrical impulse? Where is that coming from?
Yeah, so that would be.
Is that like the nerves, or?
Yeah, so it's the nerves within your heart are like communicating to each other, and they will, when they're stimulated, they will tell your heart to beat. So that's how come electricity works really well to convert rhythms, to slow people down, to pace them, to get them to speed up faster, and then to actually like shock them back into a rhythm, because it's all electricity.
Yeah. So what's gone wrong when they have a rhythm but the heart's not beating?
It's probably more a pump issue.
Oh, okay.
So that it might be that there is, a clot in there. That is why they stop beating, or a faulty valve, or just, different things like that is often why it probably stopped. Not actually but sometimes it's an electrical issue as well. So then those people, you will not see a rhythm on your defibrillator, and most times those are hard to get back.
Oh, okay. So it's better if there's a
if there's a rhythm on there.
So what is the compression trying to do? Is it trying to work out a clot or something like that, or what are you trying to do with that?
So what you're trying to do with your compression is to get blood flow to the whole body.
Oh, okay. So you're kind of pumping. You're pumping the heart. For them, kind of. Is that the idea? Okay.
Yeah. You're pumping the heart for them so that you get blood to the brain, and you can maintain perfusion to all the tissues and everything.
So that's why compressions can go on for like half an hour sometimes. Is that?
I've seen it longer than that.
Okay, yeah, and because you're continuing to keep them alive by keeping the blood going.
And then, so that this is kind of going into another topic, but if someone wants to be an organ donor, you need to keep doing CPR until you get them to the operating room, because you want to keep perfusing that brain and other tissues. Oh,
okay. So it actually won't be usable if they wouldn't get blood for long enough. Okay. Yeah.
All becomes like they die so fast.
Yeah. Fascinating. Yeah. Other procedures that you were going to talk about?
So then obviously airway, like I mentioned earlier, we do a lot of airway management. So oxygen, we give a lot of nebulizers to people that are coming in respiratory issues.
What's a nebulizer?
It's like a moisturizer that you pretty much put up to someone's mouth, and they will just like breathe into it. So the oxygen pushes the medication into your lungs.
Okay.
Yeah. And then also we would put in like oral airways, anything before intubation. So that's one thing a nurse does not do, is actually do the physical intubation.
Right.
We can do everything up till that point and then manage the airway after.
Okay.
So I can put in other airways, like what they call LMAs, look very similar to endotracheal tube, but they just don't go past the cords in your trachea.
Right. I think Cam talked about that a little bit. Yeah.
That would be, and then ventilator management. So when there's not an RT there, then it would be us nurses that take care of all the like handling that. And then other like things, obviously we do a lot of wound care, dressing lacerations, helping with casting, splints, all that type of stuff. Yeah. So yeah.
Well, you do see a lot of a diverse number of things. That's
very diverse.
That's for sure. Yeah. Yeah. I'm curious if you have any stories to share about that kind of describe some of these situations that you've been talking about. So I put it down here. What are some of the most stressful situations that you've experienced? So do you have anything to share about that?
I kind of actually had to laugh when I saw this question because I think most people would think everything I do is quite stressful.
Oh, I would think
on
so,
a daily basis. And it honestly, it takes a lot to stress me out in my job.
Okay.
I talk to my coworkers and people are just like, I might feel really stressed inside but just don't look it. But some of the most stressful things that I could think of is I remember one day I was charged and I got a pre-alert that I had multiple casualties coming in from a motor vehicle accident.
Okay.
And this was in a very rural hospital. We don't have very many staff. And so I knew right away that I did not have enough staff to manage the amount of patients that I was receiving. So had to go into what we call code orange stage.
Okay.
And what a code orange is a situation where you pull all the resources you have in your hospital to one area, plus recognizing that you need to call in additional resources. So
like from outside the hospital?
Yeah.
Okay.
So in that situation, obviously you had to call in more physicians, more nurses, more lab techs, more x-ray, like everybody.
Okay.
And
so are you calling people from other hospitals or people that work in the hospital that were off at the time?
It was people in our hospital that are off.
Okay.
Yeah. So anyway, I had to get people to start working on phoning people, right? Because that doesn't just happen. And plus, we wanted to get prepared for all these casualties coming in. So we had an idea of how many were coming in. And so I started getting like one nurse per bay to just set up the bay, and you wanted to make sure you have everything available. Anyway, so what happened was then that everyone, like we got people in there until the casualties came. We actually had enough staff as patients were arriving. So we would like have one patient come in and be like one physician, two nurses. And we were just like doing that with all of them. Anyway, I was still a very new nurse at that time when this happened. And I was working with a more senior nurse. So when I initiated the code orange, and then before the patients all arrived, I actually asked to trade positions because I was like, she's ran code oranges like many times in her life, and I had never done this before. And I was just like, I wanted things to roll smoothly. So I asked her to switch with me, which she ended up doing. And I ended up taking a patient, and she orchestrated the whole like way the department ran that night. But one thing, so that was very stressful in terms of like not, getting everything set up and whatever all. But one thing that I've looked back on that situation a lot is how orchestrated everything works together. So it was to some staff that were looking on to the situation were like, that just looked like chaos. But being in the middle of the situation, it didn't feel like chaos. Like it felt very well controlled. Like it was like everybody knew exactly what patient they were with, what they were doing. And even if there was like piles of staff running around and it probably looked like chaos, it's just amazing how orchestrated it felt. So that was one of my most stressful situations I could think of.
Well, and it's there's obviously a plan and procedures in place. Like even the fact that you have the terminology code orange to know these situations, and and they probably don't happen a lot. Is that a pretty rare thing, or that?
Yeah, they're fairly rare, I would say.
Okay, but they still are something that happened and people had experience with. So
I've only ever actually been involved with that one.
Okay.
I've been doing it almost 3.5 years.
So it's not something that happens every year, though.
Is. Yeah.
Yeah.
So and how, you don't necessarily come across it every day.
Yeah. Well. Any others that you?
Another situation that I thought about was, so like I mentioned earlier, we do a lot of transfers as nurses with patients, and I was transferring a patient the one night to a more acute hospital. The patient didn't have a specific diagnosis. There was a lot of it was a very weird story. We couldn't really piece the whole puzzle together.
Okay.
And they needed an ICU situation and be assessed by like a ICU doc. So I was en route with this patient. We were probably not quite halfway en route when my patient still talking to me, but suddenly I have no pulses. I have no radio pulses. Patient starts looking really diaphoretic. She's still talking to me. And so I said to the paramedics, I was like, we need to stop at the closest hospital. And they were like, no. And I was like, we don't just stop. I said, we need to stop at the closest hospital. And the paramedic with me in the back, didn't get it because the patient's still talking to me.
Okay. And
I was just like, I did not feel good about the situation. I did not think we were going to make it to another hospital in time.
Is that really breaking protocol to do that? Yeah. Is
that why really they?
Is.
Yeah.
Okay.
And so finally, the paramedic in the front heard our conversation and was like, "Okay, so what do you want me to?" I said, "We're coming in a CTAS 1, which is your highest, right?" And so that was fine. The paramedic patched in, and we were able to get to the local hospital, or the closest hospital, and the patient coded as they're walking through the door. So now I've lost a heartbeat.
Okay.
So anyway, we were able to resuscitate and continue on our way, but that situation was one of those situations too, where you feel really helpless in the back of an ambulance with absolutely no resources, no physician on board. I was just that's the best thing I knew to do at that time.
Okay. Yeah.
And yeah, I think the paramedics and we had some good conversations after that, and they didn't understand why I wanted to stop, but the patient was talking to me, so I didn't want to say, I've lost pulses, this patient's going to die.
Okay.
You don't want to tell a patient they're going to die when they're still talking to you, right?
So did the patient go unconscious before you got to the hospital then?
They were conscious about till we got to the door, and then as we were unloading, they went unresponsive and coded. So.
Is that so? You said that you were kind of saying that's a strange situation that you're still having a conversation and
very strange. So it turned out it was a mitral valve thrombus, which is actually a clot in the one valve of your heart, which is very, very rare. It's extremely rare. And even to see a patient go into what we call, that would have been considered cardiogenic shock, is again very rare.
Okay.
And it was one of those situations that I didn't know exactly what was going on, but I knew it was serious.
Something was wrong, yeah.
And you can't survive if you're not getting any blood flow to your peripheral region.
Right, yeah. Wow.
Yeah.
In that situation, are the paramedics in charge? Do they have to make the final decision if you're going to stop or before you get to or can you order them to pull into the nearest hospital?
Yeah. So when a nurse is in the back of an ambulance, they are the most responsible for that patient.
Okay.
So any call I make, they're supposed to go with it.
Okay. Yeah.
Even though we're breaking protocol because now it's it's all political issues,
right,
with run numbers and all this. They would have had to call into their dispatch and tell them that I made them revert and have to give a good explanation why and everything.
And probably had to file reports. And
exactly. Yeah, there was a lot of paperwork, I think, on their end, but after the situation, they understood, I think, why we did what we did.
Yeah, well, it's great when those things turn out when you have to make
and the
a tough call like that.
Yeah, it was really just like the right place at the right time. They survived. They could have easily not made it either, but they did happen to make it that time, so that was good.
Yeah. Yeah, any other stories that that you wanted to share?
Another situation that I thought of, and it's a transfer again, and I think probably it's because these are some of my most stressful moments here with the least resources and kind of like have to do with what you have. But this was a patient where a physician was actually on board with me because the patient was like very critically ill.
Okay.
Whenever we think they're potentially going to need to be intubated or anything root, then we'll always bring a physician on board. So anyway, there's a physician on board, and we were taking this patient to another hospital, and they were having like a lot of abdominal pain, which turned out to be a rectus sheath hematoma, which is a lot of like bleeding in your abdomen.
Oh, okay.
So anyway, this patient is like, their blood pressure is extremely low, so we're infusing like units of blood. Actually, like I'm squeezing blood in the back into this patient en route, and yet the patient is just having continuous excruciating pain. So we had grabbed a lot of like pain medications and stuff for en route and figured we had like sufficient. When we were hardly not even halfway to our destination, and we are completely out of pain medication. And the physician on board that day is like, we need to stop at the closest hospital, which this rarely happens. It happened to me like twice within a very short time. Anyway, the physician was like, we need to stop. So we got the paramedics convinced to stop, and he went in and got some more medication, and we went on our way. But that whole trip, neither of us knew if the patient was going to survive. I never sat the entire trip. I'm like literally just squeezing blood because we cannot keep the pressure up. And the physician is like just giving like continuous pain medication because we cannot get the patient's pain under control as hard as we try. Because what's happening is everything we're putting into them is bleeding into the abdomen. So the abdomen's like becoming like this huge ball of blood.
Oh, wow.
And all the fluids from all the vessels and veins are like just flowing into that.
Right.
So we were like, all the resources we had on board that day were pretty much diminished till we got to the hospital.
Like the one you stopped at? Till we
dropped the patient off. So we stopped and got more. And again, we were almost out. Like, we were both just like, yeah. So again, another situation, I think, where, you know, we're so used to having the resources available to us in adequate supply. And when you're in situations where you don't have that, it can, or for myself anyway, it kind of just like creates this stress knowing I would have it if I'd be in the hospital. But I don't have it en route. Compared to like when I've lived abroad and worked in limited resource areas, I know I don't have it. So I don't really, I do with what I have. But when I know I could have it, I'm just like, if we had this and if we had that.
No, that's, I think I hear what you're saying there, that that you're used to having those situations, or if you were just in the hospital instead of in the back of an ambulance, it would be a different story. Do you ever get into situations in an emergency department where it just is so busy that you, like, beds are full and you don't have places to put people that are coming in? Does that ever happen?
Yeah, so I would say that happens more than we would like it to happen. You end up with all these patients that are admitted to units per se, like to inpatient units and stuff, and they don't have beds. Right. So they all get left in the emergency department, and then that puts us in a huge bedlock. And that can be really challenging because Because by that time, you know that these patients are admitted, they're stable, but you can't just get them to sit in a chair. Like, they need a bed because they're admitted.
Yeah.
And yet you have your, emergencies coming in that really need beds. So I feel there's a lot of challenges with flow and getting patients to the right place and moving them through.
Yeah.
Definitely.
Do you find that there's certain times of day or certain times that are busier than others, or is it not really predictable that way?
I would say probably you can kind of predict that your evenings are going to be a lot higher volume than say 6 a.m. per se.
Okay.
Or, Friday nights and Saturday nights are going to be a lot higher volume than your Monday night.
Okay.
Just because that's when everyone's going to be out drinking and partying and overdoses are going to happen. And,
okay. Yeah.
Yeah. Holidays, you always know holidays will be busy because your traumas will be coming in.
Okay.
Very common.
Yeah. So you can predict some of those things?
Yeah, you can.
Yeah.
Yeah.
Yeah. Did you have any other stories that you were wanting to share?
So one story I had to think of, and this is a very rare, I had never seen it before. I had this patient come into the emergency department the one day with their eyeball popped right out of their socket, which is called globe luxation.
Okay.
And the patient, so I had never seen this before and honestly did not know what to do when I saw it. I was like, what do you do with an eyeball out of the socket? Because it's something you don't really learn a lot about anywhere. And so I decided to do what I always do, is my eye exam, and I realized that this patient could see just fine out of that eye.
Really?
Because the optic nerve wasn't damaged. So the ball popped out of the socket when the patient sneezed.
Okay.
And the optic nerve had not been damaged. So I realized that the patient could do all my eye exams, everything was fine, but the eyeball's sitting outside the socket.
Wow.
So I asked the patient what was going on, and they were they didn't really actually know. They said their friend thought they should maybe come because their eye looked kind of funny.
Okay.
But I was like, do you want to have a mirror? Because they had no idea that their eyeball was sitting outside the socket. So what we did is we just took cold compresses and put it on and got them to ophthalmology so that they could put the eye back in, and I think they actually did okay with it.
Okay. Did it take surgery?
I don't know if they would have actually done any surgery, probably just pressure and popped it back in.
Okay. Yeah.
And then I'm sure they put a patch on and stuff just to make sure, because you want to strengthen that ligament and everything.
Yeah, no, I can imagine that would be something that you don't see regularly. Wow. Mm-hmm.
Another situation that has impacted me a lot was a young teenager who came in quite frequently, and they were heavy into drugs. So saw them very frequently with overdoses. And the one night I had a chance to chat with them and just, ask about life and what their plans are for the future, what they want to think about, if they are going to do university or what their plans are. And anyway, it kind of formed a friendship, I guess, and they became quite open with me, and I realized that they like to draw. So that night I gave them pencil and paper and told them, draw me what your life looks like.
Okay.
And I don't even remember what the picture looked like. I kind of left it, and the patient got discharged. Didn't see them again for a couple months, which to me was very concerning, because when you see people that frequently, there's some that we see all the time, you start wondering, are they doing okay? Did they eventually overdose and took their life, or what happened, right? And so a couple months later, I was triaging them one night, and this patient's name came up on my board. And so I called them in, and they walked in, and they looked all happy and well kept. And I was like, well, what's going on? Anyway, we proceeded with our triage. And at the end of the triage, they were like, I just wanted to tell you, I just wanted to thank you. I've took your advice seriously. I've quit drugs. I'm completely clean. And started telling me like what their plan is for their future and everything. And I have no idea where that patient is today, but like it really did something to me that I was like, you know what? If I just take that moment to like listen to people and, you know, impact them however I can, it's amazing what results you might see. You never know, right?
Yeah. Well, that's fascinating. We we don't know what the what the little things that we do are going to, and how God can use a situation to work with someone. I mean, we're just doing our small part, and like you said, you don't know what that's going to do, but yeah, that's an incredible story of and that you got to see those results. Like often we don't know what the outcome is when we, even if we do the right thing, and it doesn't always bring a good outcome, and we don't always know what happened in a situation. But that's really neat that you got to see that. You said a few months later?
It was a few months. Yeah.
Wow.
Which is something obviously with the work I do, you don't often get to see your patients a second time, right? So you don't know what happened. Or
it's not your job to follow up and things like that. Yeah. Very good.
Yeah. One other story that I always think of is, and this kind of demonstrates how you never know what's going to walk through the door. So the one day, this patient walked up to the registration desk, and I noticed they had like this huge blanket over their shoulder. And I wasn't sure if they were carrying a baby or what was going on, and called them into triage. Noticed that they looked like quite like pale and diaphoretic, and was like, do you want to come like lie on a bed? Just because I wasn't they just didn't look well. They were like, yeah, that'd be fine. I said, what's going on? And they're like, well, I just have a little small laceration, like it's a small cut to my arm, just need a couple stitches. And I was like, okay, that's fine. So I got them on a bed and went and was like gonna take the blanket off, and they're like, oh no, you don't want to look underneath. And I was like, but I need to see this laceration. They're like, oh no, I don't think you want to look. And I was like, yeah, I do. So anyway, I took the blanket off and this huge dressing. Their arm was hanging on by a thread. It was like pretty much a full amputation, what we would call that.
Okay.
And here they had got their arm like caught in a auger, like one of those feeding augers, and like completely like pretty much severed. But they were calling it a small laceration.
Wow.
And had I not seen that patient come to registration and be like, something looks a little off, they may have went and just sat in the, waiting room to see a nurse, because they told registration that, just a little small laceration, right? Like it wasn't anything traumatic, and they looked pretty calm and collected.
Wow. So is it some people can just tolerate a situation like that better than others? Is that kind of what you're dealing with there? Or?
I would say so. Yeah, because you may have the next person come in who might have, a paper cut on their finger. I've had this, and that's their worst thing they've ever had.
Okay, yeah.
Right? So you really have to, everyone perceives pain and injury so different.
Okay, yeah.
You really just need to assess the situation for yourself. And
wow. So in that situation, were you able to save the arm, or how does that?
They tried. I don't honestly know what happened, because they would have got sent to that'd be considered a trauma ortho situation.
Right. Yeah.
So we would pop that little piece of arm that was left on ice and get them to the closest hospital that could fix it.
Wow. Yeah. No, I'm sure I'm not surprised that you have stories of situations like that you see. So that's fascinating. Did you want to say anything else about the situations that you run into before we talk about some advice that you have?
I could probably talk about stories all day, but I can move on. It's fine.
Yeah. Well, thanks for sharing those stories. It was fascinating. Yeah. So what advice would you have for those that are maybe thinking about working in Emerge someday or starting out? So from the experiences that you've had now, do you have any advice to pass on to others?
So I think one thing that people need to come into emergency nursing with is like having a passion. It's not for the faint of heart. Like you need to be able to deal with a lot of things.
Right.
And like I think it's something you need to know that you've been called to do, to be able to like just have that passion for the work, because I see a lot of nurses that you burn out really quickly in that department.
Yeah.
Because there's so much, and you know, people aren't maybe ready to deal with it. Depends where they're at in their own life or what other external situations may impact them. I find can be a huge factor into how long someone's gonna maintain.
And like by passion, do you mean like love the work, or do you have any idea what are some of the things that are needed to be able to stay at it?
So I think definitely a love for the work. Like, you know, do you want to go to work every day or do you not?
Yeah.
I think that's like that for any job, right?
Yeah.
And just a love for people and a love, like just want to make a difference in people's lives, I think are really huge factors that need to drive you into that work. But in saying that, I think it's probably one of the most rewarding places that I have worked. I mean, I've done a lot of other things too, but it's definitely, you can feel like you made a difference in people's lives, even if you don't always see the results, but sometimes you get to, because you're working with people in very vulnerable situations.
Right.
And most times people haven't chose to come to you.
Yeah.
They just end up there and they're like, oh, like, I'm so sorry I wasn't planning to come today. Well, no, you weren't planning to have this emergency happen, right? So to try and just be there and walk with people. Yeah,
no, that's great advice, I think, for someone to think about if they're considering it as their career choice or something to try out. So that's great. What's more likely for someone that's listening to this is that they might have to visit the ER sometime as a patient, or we'll have an emergency that they'll need to go to the hospital and visit the ER, the emergency department. So do you have any, like, from your side of it, being a nurse in the department, is there any ways that we could make your job easier, or things that we could do to help you? I mean, sometimes some people can't choose that, but maybe are there things that people do that make your lives easier?
So the first thing I can think of is bring all your medications, or at least have a list in your wallet. That is very helpful. And take, for instance, someone who is in a motor vehicle accident. They come in, they can't talk to you. I have no idea what medications they might be taking or if they have any allergies. So the first thing we always look for is your wallet. And to see if there's a list. And some people will have a list in there and some don't, but it's really helpful in guiding us to know what we can order and what you can't order. And what to watch for. So that's something I recommend to everybody.
So would it be helpful if, for someone like me who's healthy and doesn't have any allergies or doesn't take any medications, should I have something like that says that in my wallet? Would that be helpful? Like, what do you go with if you don't have any information?
We assume there's nothing.
You do, yeah.
But I mean, there's sometimes when people actually have something and obviously we had no idea. You're gonna kind of weigh your risks and benefits and be like, well, the best you can do is at least try and save this person. If they react, then kind of have to deal with it, right? But
it might not be your most important concern at the moment.
Exactly. And then another thing I always tell people is, so don't be scared to use Tylenol or ibuprofen or anything like for pain or fever before coming in. We'll gladly give you some there, but we like to have seen that, you know, someone tried something and they can tell us it worked or didn't work. Helps us know if we should prescribe it again or if you need like a stronger medication or something. So that's something that I always tell a lot of people. And then lastly, I think kind of like we talked about earlier with the whole triage thing, if you have to wait, be thankful because it means that you're probably not going to die within the next couple of minutes.
So don't complain about a long wait.
No one likes wait times, right?
Yeah.
And we don't like it either when people have to wait 6 hours, which doesn't always happen, but it does sometimes. And but it might be that there was 4 or 5 other really sick people that came in
Yep.
that are consuming a lot of resources and time.
Yeah. No, that is good advice. I've really enjoyed learning some new things about the work that you do, and it was great hearing your stories as well. So yeah, thank you for that. Is there anything that you wanted to get a chance to say that we kind of missed talking about, or anything that you'd like to say here yet before we close it out?
So I'll probably just take this opportunity to be a nurse and promote health.
Yeah.
I encourage everyone just to stay safe. So like use the protective devices that are in place in terms of like your tools or anything at your workplace, farm equipment, might save your fingers and lives.
Seatbelts.
Yep, seatbelts, helmets, another huge one. And then another very key thing we didn't really talk about is strokes. So seeking medical help immediately. So if you or your friends have like this sudden onset of headache, dizziness, nausea, slurred speech, any difficulty finding your thoughts and like sudden like partial weakness, try to get to the hospital as soon as you can, because we can only treat within a 4-hour window. And then after that, there's other things that can happen, but the chances of saving your brain are like within a 4-hour window. So it's a very small window.
Yeah. So that is really critical then, that it's seen right away.
Yeah.
Wow. Yeah.
So just something to pass on to listeners, and stay safe.
Yeah, no, that's great advice and just good information to know. As far as some of the protective devices that you talked about that are in place, and well, something like seatbelts and helmets is something that we all probably can use or have the opportunity to use. Do you notice, like from your experience, have you seen significant differences made when those are used in a serious accident or something like that?
Definitely.
Yeah.
Yeah. Car seats, helmets.
Oh, yeah.
See like the difference of having head trauma versus not. I mean, it's definitely impacted significantly. Other protective devices. So I'm thinking particularly of like saws and things like that. So, and obviously I don't work in a woodworking shop or with these types of things, but I see a lot of injuries. So guards, I guess, that you can have on some of those devices when they're used, you don't see them. The people I've had didn't use those guards or didn't use, whatever, and they've lost, fingers and stuff because of it, right? So it's often just a one-off thing, and someone's just like, well, I just need to quickly do this. Yeah. But then that's the time when you
I know, and it's so easy to think that, like, oh, I'm just driving for a minute, or just across the street or something like that, or I'm just going to cut this one piece. And usually we're fine in those situations. Like we'll do something where we don't use the equipment correctly, and we don't think about it because something doesn't happen. But it's those of you that see those situations on a regular basis, and those that have had a situation happen that it just would have been so simple to take the extra 30 seconds to do it correctly.
Yeah, it's so easy though. I think we all do it.
I know, yeah, but it's a really good reminder. So thank you for bringing those things up. Anything else you wanted to say?
No, I think that's everything.
All right. Well, thank you so much for sharing your expertise with us. I've really enjoyed it and learned a lot. So thank you. Thank you everyone for listening, and thank you Alyssa for sharing your knowledge with us. One clarification that she wanted me to make from the episode is when she's talking about defibrillation and talking about the rhythms that they shock on. She wanted me to say that not all rhythms are shockable. And as a clarification, a normal sinus rhythm is not a shockable rhythm, as there are only 2 rhythms that are shockable. So yeah, thank you, Alyssa, for that clarification and for everything that you taught me during the episode. I really enjoyed that. And I was fascinated by all the collaboration that goes on within the emergency department, how many different types of healthcare professionals work there, and then all the coordination that they do outside of the department and things like that, and how coordinated it needs to be during stressful situation with traumatic injuries or motor vehicle accidents or things like that come through. So really enjoyed that, and thanks for sharing with us, Alyssa. If you'd like to connect with the show, I would love to hear from you. You can send me an email at contact@everydayexpertise.ca. Love to hear your feedback for the show or suggestions that you have. So yeah, don't be afraid to share those things with me. You can also check out the website, everydayexpertise.ca. That's all for now. Join me again next week to learn from the expertise of everyday people.